The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're fortunate this month to be talking to Dr. Mitch Strominger from Reno, Nevada, former past president of the Nevada AAP and a pediatric ophthalmologist. Thanks for rejoining us, Mitch.
Thank you. You know, I love the AAP. People ask you, where's your medical home? And as a surgical subspecialist, when you take care of kids, you really have to look to the AAP because some of the other medical societies, it's mainly adults. So we just love the AAP.
One of the great things is it really feels to me like the AAP's first priority is making sure that kids get the best care they can.
That's the whole bottom line, right?
Yep.
Take care of the kids.
Yep.
We may not get paid for it, and that's why I don't have any disclosures because you didn't have to yet, but that's a whole other issue, right?
Please send your disclosures to disclosures@vcurb.com. That's like the Mitch Strominger can do to get rich.
I don't know what it is, but especially in ophthalmology, there's so much stuff out there that people are working with pharmaceutical companies for new drugs, or some of these manufacturers making all these fancy intraocular lens implants, or all these fancy machines looking at macular degeneration. Not much out there for kids. So maybe we need to come up with something. If you have an idea, let me know.
Yeah, we'll think of something. All right. So over the past couple of weeks, we talked about the anatomy of the conjunctiva. We talked about viral conjunctivitis, and we talked about bacterial conjunctivitis. So we've talked about everything that can give you pink eye. Is that right, Mitch?
I think we only hit on two.
Well, let's keep going then.
You have to understand, I did a year fellowship in pediatric ophthalmology, so there's got to be more than just two things.
You can't do it in 45 minutes. Is that what you're saying?
Yeah, right. Exactly. I wish it was that easy.
Let's talk about allergic conjunctivitis. So how does allergic conjunctivitis look different from the last two that we talked about?
Well, I think a lot are how the kids present. So a lot of times they'll present with eye itchiness. Their eyes may just be a little bit red and irritated. A lot of times they have that sort of allergic salute where they're rubbing their nose and they're just uncomfortable. And so when you look at the eye itself, sometimes it's hard because the itis is inflammation. The conjunctiva is going to be inflamed. But what you can do is you see this sort of stringy, clearest discharge. So in viral conjunctivitis, you don't have really much discharge. And bacterial conjunctivitis, you have that mucopurulent type of discharge. And in allergic conjunctivitis, you sort of have this stringy, clear discharge. And sometimes the kids are sort of picking at their eyes and they actually pull out these sort of pseudomembranes. It's this material and it's a sort of stringy material out of their eyes. And that's a good clue that there's some allergy going on.
A lot of times we think of allergic conjunctivitis seasonally. We think we're going to see it in the spring, the early summer and fall, the way we see hay fever. But that's not necessarily the only time we're going to see allergic conjunctivitis. Is that right?
Well, that's probably the more common, right? You have this seasonal perennial allergic conjunctivitis. And here in Nevada, we have it during sagebrush season, right? I'm from New England. We didn't have sagebrush in New England, right? We had oak trees. We don't have many oak trees out here. We do get a little bit in the fall with the leaves and in the spring with the pollen. So a lot depends upon what environment you're at. I mean, here in the northern Nevada, we get a lot of ocular irritation and allergies during fire season when we get all these forest fires. These kids are coming in completely miserable. So a lot has to do with the environment that they're in. It doesn't necessarily have to be a seasonal thing too. I did some of my training in New York City, and we actually saw more allergies in kids in the wintertime in the city. What was causing? Well, it turns out these kids are inside, it's dusty, there's cockroach dander and dust mites all over the place. So they were getting allergic conjunctivitis related to their environment at the time in the winter.
Yeah. So watching for the kids with itchy eyes, maybe a stringy discharge, and maybe seasonal, maybe the cat, maybe a lot of other things.
Yeah, absolutely. And the problem is that when you have these kids with these chronic allergic conjunctivitis, the parents are like, should I get rid of the cat or all this? And sometimes I'll refer them to the allergist, and the pediatrician's already jumped on it too. And a lot of times they'll be on oral antihistamines to try and sort this out. So I typically like working with the pediatricians or the allergists if we can identify there's a specific time of year or something that the kid has an allergy to. But most of the time, we just don't figure it out.
So what is the best treatment strategy?
So it's primarily supportive too. If they have other systemic signs, then I do usually recommend an over-the-counter antihistamine like Zyrtec or something like that. But from the topical standpoint, we have a couple options on what to do. We have antihistamines. We have antihistamine vasoconstrictor combinations. We have mast cell stabilizers. We have antihistamine mast cell stabilizers. We have steroids. We have nonsteroidals, and we actually have cyclosporin. It's sort of tough to figure out exactly what to start with, but I can tell you what I don't like. I always ask the parents if they're using some sort of eye drop at home. A lot of times they use it and they give it to their kids, and a lot of these are the over-the-counter antihistamines. And the problem is that if you look at some of the ones that are actually more popular, something called anything with an A after it, like Nafcon A, Opcon A. I'm just mentioning a couple trade names. What those have is nefazoline and phenyramine. And the problem with those medications is that they take the red out. That's what the A stands for. So your Visines, A's, and all that sort of thing. And the way it takes the red out is actually it's a vasoconstrictor, right? So that's what takes the red out. When I use dilating drops, I use 2.5% phenylephrine drops to dilate the pupil, but it also makes the eye white because it's a vasoconstrictor. And so what happens is that the eye becomes white and quiet, but it's very short acting. So all of a sudden you get this rebound vasodilatation a couple hours later, and all of a sudden the eye becomes redder. So that's the bad thing about using these compounds that have the A after it, because they are vasoconstrictor. They also can cause a little pupil dilation, not as much as using typical 2.5% phenylephrine to dilate the pupil for examinations, but it can lead to pupil dilation and cause blurry vision. And the other thing is that if you use these sympathomimetic vasoconstrictors, it can also cause some central nervous system depression in infants and kids. So they're really bad from that standpoint. And then you're looking at the second component of it, which is the phenyramine, and that's a very short-acting antihistamine, and that's dosed every 3 to 4 hours if you look at the package insert. So you're putting a drop in, causes vasoconstriction with rebound vasodilatation and a very short-acting antihistamine. So I think those are really bad for kids, and I hope the pediatricians would educate the parents not to use those in kids. So then you have these other combinations, and you used to have some topical antihistamines that were typically just topical antihistamines. Those aren't really on the market anymore because these antihistamine mast cell stabilizers came out, and they seem to work pretty good. So that's your olopatadine and ketotifen. And it's interesting how they came out, because if you look at the mast cell in the conjunctiva, and I always ask this question to the pediatrician sort of as a fun thing. You have mast cells in the lung. Those are tryptase mast cells, and you have tryptase kinase mast cells in the skin and connective tissue. So which one do you think is the one in the conjunctiva? Well, it turns out it's actually similar to the one in the skin rather than mucosal membrane of the lung, or
Oh,
nasal
interesting.
mucosal membrane, which is very interesting. So
Yes.
if you look at some of these mast cell stabilizer antihistamine combinations, some were formulated specifically for the tryptase kinase mast cell of the skin and connective tissue, like olopatadine, and the others weren't, but they are formulated in such a way that at specific concentrations, they work pretty well. So usually I start with an over-the-counter. You always have to worry about using a steroid, right? You can use a steroid, and I think what pediatricians need to know, there's some formulations out there of low-dose lodipredinol, which is a steroid, and that's being marketed for allergic conjunctivitis. And you have to be careful because if you use a steroid for a long period of time, it can cause a couple things. Number one, it can cause the pressure to go up in the eye, and then you get glaucoma, or it can actually cause cataracts. Long-term use of corticosteroids for allergic conjunctivitis is bad. And then we'll talk about maybe some of the other allergy types of problems, and then you can use maybe a cyclosporin or something like that.
So would cyclosporin come in your approach to regular allergic conjunctivitis?
Typically would not. I usually start out with a mast cell stabilizer antihistamine combination. Actually, I forgot to mention one, which is an old drug, and actually I think it works pretty good. That's cromolyn,
Oh, yeah.
and it's pretty cheap. And the problem with cromolyn, it's more of a mast cell stabilizer, and it can take about a week or two to kick in. But you can use it really long term. So if I have a kid who we know during a specific season they're going to have problems, sometimes what I'll tell the parents, like in the spring, for example, I might have the parents start the drops sometime sort of towards the end of March, at least here in Northern Nevada, because our flowers start coming up in April and May. Whereas in New England, we didn't get flowers till July. So I would have them start out using cromolyn, and you can use it twice a day. And it takes about 2 weeks or so to kick in. And then a lot of times they're really good for the rest of the season. So I actually like cromolyn. It's generic and fairly inexpensive. And sometimes I use both. So I'll tell the parents, okay, use the mast cell stabilizer antihistamine combination like cotadifin, use that twice a day as well as the cromolyn. And after 2 weeks or so, you can stop that and just use the cromolyn.
Well, one of the challenges of treating allergies in general, I think, is that none of these things suck the histamine back in. And so it usually takes a certain amount of patience for the symptoms to abate while you're stopping the ongoing irritation.
Right. Well, there's a couple types of ocular allergy that I think we also need to talk about
Yeah.
besides your typical seasonal perennial, because these are the kids who are really in bad shape. And these are the kids, and I see it fairly frequently here in Northern Nevada. And that's something we call vernal keratoconjunctivitis and atopic keratoconjunctivitis. And those really are the masqueraders. So if I see a kid who's been treated with conjunctivitis for multiple antibiotics and it's not getting any better, I can almost guarantee over the phone that it's going to be one of these two things. Vernal conjunctivitis is really a severe type of allergic reaction to something. We see it a lot here in Northern Nevada. It's probably because it's really dry. We don't get much rain. And in the summer, we get all the forest fires. So we get a lot of smoke. And so what happens is they develop this really severe conjunctivitis. Sometimes you can tell just by sort of looking at the eye and also talking to the parents, because the parents say, oh, the eyes are really glassy looking. And right along that limbus, there's like these globules, and some parents describe them as fish eggs. And you can see this if you just take your pen, like right along the limbus there are these gelatinous type of materials. Sometimes you have to lift the upper eyelid because it's more in the upper eyelid, but sometimes it's right along that line that's more exposed nasally and temporally along the limbus. And what that is deposition of IgE. And those are called Horner-Trantis dots. And if you have chronic corneal transistots, what happens is that's chronic inflammation at the limbus, and you can get new vessels growing up into there. So you get this neovascularization in that area. And when you look at the eye, it's sort of more red right around that limbus. It's that sort of ring all the way around the eye. The rest of the eye might not look so bad, but right around there, it looks really bad. And the problem with that is that, well, you can get chronic neovascularization, but then you can get these things called shield ulcers. So a shield ulcer is where the epithelium denatures, and then what happens is you can get scarring. And it's sort of separate from that limbus by maybe a millimeter, and then all of a sudden new vessels grow in there, and then you lose your vision. And that's really difficult to treat. And I'll tell you, I see probably one case of vernal conjunctivitis every couple of days during certain times a year. And so I think pediatricians really need to understand this, because a lot of these kids have been treated for months for other problems, and they never really were recognized. And then once it gets to this point, they need to be treated with steroids, pretty high dose steroids, just to get things quieted down. And once it quiets down, because you can't keep kids on, or anyone on, topical steroids for a long period of time, then we'll use cyclosporin. And there's a formulation now that came out, and I'll just mention the trade name. It's called Vercasia. It's a cyclosporin that we use now to keep these kids pretty quiet. The problem we're having is the insurance companies don't want to really pay for it because it's not cheap, but it prevents the kids from going blind. So sometimes you have to argue with them. And for some patients, we've found some compounding formularies to make it for them as eye drops. So that's vernal keratoconjunctivitis.
The clues that I should be looking for there are conjunctivitis that doesn't clear,
Right.
looking for these deposits around the limbus, and among other things, that I'm not having success, and I talk to you.
Right. And the other thing is, if you see abnormal blood vessels growing into the cornea, which a lot of times is pretty obvious, then that's the case. A lot of these kids are just miserable. Their eyes have been red for weeks and weeks before they finally have gotten in to see me.
Okay.
And so that's vernal keratoconjunctivitis. There's another type of conjunctivitis that's somewhat related. It's also immunoglobulin associated, and that's atopic keratoconjunctivitis. So atopic keratoconjunctivitis is sort of a similar thing as this limbal vernal, but you don't get those sort of globular deposits along the cornea. What happens is that these are kids with atopy. So a lot of times they get inflammation, these chronic conjunctivitis, and then what happens is the cornea dries out, and all of a sudden you get new blood vessels growing in there. So you have these ulcerations of the cornea as well, and corneal neovascularization. It can be exacerbated by certain allergens like wildfire smoke and things like that. And we actually see a fair amount of this as well here in northern Nevada, because it's also very dry. And so these kids, I also always check to see if they have atopic signs. I pull up their shirt sleeves and check to see if they have dry skin or any eczema. And then that would be associated with atopic keratoconjunctivitis. The treatment tends to be the same as the vernal. You have to get them on steroids and then sometimes the cyclosporin.
So any corneal neovascularization, that's a very urgent condition.
Oh, yeah. These kids need to be referred because we need to hit them hard right away to prevent things from getting worse and make sure they don't go blind. I've had kids who've been delayed in terms of their treatment, and now they're in trouble.
That's tragic. Anything else on the atopic or the allergic conjunctivitis?
Well, there's a type of allergic conjunctivitis that we tend not to see quite as much anymore, and it's called giant papillary conjunctivitis. And this is caused by chronic repeated irritation from contact lenses. Now, kids are wearing contact lenses younger and younger. And so in the old days, you'd have those gas permeable lenses. They would last like 3 months, right? So you take them out every day, you sort of enzyme them and you clean them, and then you put them back in the eye. And they were fairly thick. They didn't have a lot of oxygen that allowed to go through them. And so we would see this reaction, especially underneath the eyelid. If you flip the upper eyelid, you see these cobblestoning papillae,
Mm-hmm.
and we call it giant papillary conjunctivitis. And then what we'd have to do is we'd have to tell these individuals, well, you know what? This is from your chronic contact lens wear. Now you can't wear your contact lens for a couple months, and they would be sort of miserable for that period of time. We tended to see this more in like college age kids or maybe a little older. But then all of a sudden we started having kids wearing contact lenses at age 7 or 8 now. And so we were seeing more of it. But we probably don't see quite as much anymore because the new technologies out there. So now a lot of kids, we recommend using these 1-day daily disposable lenses, which are thinner. They tend not to cause as much irritation. They certainly don't collect all the material that you would if you wore a contact lens for 3 months. By the time 3 months went by, you got a lot of material deposits on the lens. So these are 1-day disposable lenses that you would just throw out, which is great for kids, I think, if you're going to do contact lenses. So we tend not to see giant papillary conjunctivitis quite as much anymore that we used to. But I always warn parents, especially if they want to get their kids in contact lenses earlier, that this could be a problem. And then all of a sudden, when they're more concerned about wearing contact lenses when they're in college or whatever, now they can't, or they have to stop for a while.
What about chemical conjunctivitis? What should we know about that? Do we usually find out what's causing it, and does it matter?
It's really important to know what the cause is if you can. Most chemical conjunctivitis, you're probably not seeing in the pediatrician's office. Most of those kids are going in urgent care, right?
Mm-hmm.
Or then maybe they do, but most of them end up going in urgent care. Something splashed in the eye. So the big thing about any chemical injury is you have to irrigate the eye. So what I always tell the pediatricians is if you can get a little bottle of anesthetic, tetracaine or proparacaine, and just keep it in the office, because these kids are going to come in screaming, even if they have like some sort of corneal foreign body or an abrasion. You can't examine them because they're in so much pain. So take this bottle and throw it in the eye, take a couple drops, not the bottle, don't throw the bottle, throw some drops in the eye.
I got your point.
Yeah, okay, good. And you know what? They'll open up and you can see what's going on. It's like a miracle, right? And I don't know, for some reason, years ago, they used to tell the pediatrician not to use that topical anesthetics because if there was a ruptured globe or something like that, and the anesthetic went into the eye, then it could cause more permanent damage. But you know what? You got to see the kid, and the chance of that happening is pretty low. So put the drop in and open the eye up and irrigate the eye. If you have a bag of normal saline, you just run it in the eye or use an eye wash or something like that. So the whole thing about chemical conjunctivitis is important to determine really, if you can, whether it's an acid or a base, right? So if you're going to get something into the eye, you'd rather get an acid than a base, because an acid denatures and sort of precipitates proteins, whereas a base is lipophilic and then it starts to degrade the tissue. So when you get a conjunctivitis in the eye from acid, typically the eye is inflamed and the conjunctiva is chemotic, but the cornea is usually pretty safe from the acid. Whereas if you use an alkali or an alkali base gets in the eye, what happens is it just sorts of denatures all the proteins. It denatures all the proteins of the conjunctiva. It denatures the proteins of the cornea. And then all of a sudden, if you denature your limbal stem cells of the limbus, that cornea is not going to survive. And the problem with that is the cornea is not going to survive. Even if you try to do corneal transplants on that cornea, it's still not going to survive because you've killed off all those limbal stem cells. Typically, if you want to give one versus the other, get an acid in the eye. But regardless, make sure that you irrigate profusely as quickly as you can.
And another reminder that eye protection is a good thing.
Absolutely.
Yeah.
Even corneal foreign bodies, it gets me when I go into the guys who are working on my car and I see them doing stuff without eye protection. I cringe. I also cringe now when I watch basketball games and kids, right? Because if you look at eye injuries in general, The number one thing we see eye injuries is now is basketball, right?
Is that right?
Yeah, because the kids are pushing, they're shoving, their elbows in the eye, fingers in the eye, all that sort of stuff. Yeah. We used to see more eye injuries even in baseball, but now a lot of the pitchers are now wearing protection. Lacrosse players wear the helmets and the face masks. Football now, you're wearing face masks. Those basketball players, I don't know. We got to get them to wear eye protection. But no matter what I do talking to coaches, we still can't get that done.
Yeah. Anything you want to say about foreign bodies, dry eyes?
We can talk about foreign bodies if you want to a little bit. Most of these things are really tiny, and sometimes you can see them when you put in your fluorescein dye. But maybe we should digress a little bit if you have time and just talk about corneal abrasions,
Sure.
right?
Yes.
That's something you probably see more common,
Yep.
right?
Yep.
So a kid comes in, the eye's painful, and they maybe scratch the eye or something like that. And so throw your tetracaine in. If you have your fluorescein dye, throw a drop of that in, or wet the piece of paper and get in there. And you really need to use that cobalt blue filter to see it. Usually it's pretty obvious. And the way I typically treat corneal abrasions is that, first of all, kids heal really quickly from corneal abrasions, more so than an adult. I mean, most of the kids heal up within 24 hours. And so I usually do recommend a little bit of an antibiotic ointment in the eye. I'm not really using to kill off any bacteria. I'm sort of using it to keep the eye moist and lubricated, and also to prevent like a secondary infection of the cornea. So here I would say using erythromycin or polymyxin ointment would be fine. I usually recommend putting it probably 3 times a day if you can. And then most of the time they heal by the next day. I don't know, a couple of pediatricians I was talking to yesterday, and they're like, oh, you need to see a corneal abrasion within 24 hours. I was like, no, I don't. Why don't you just have them come back to your office? If the kid seems fine, they're not in any pain, I don't need to see them. Or you can even call them up. How's the kid doing? Kid's doing fine. They're back doing their normal thing. These corneal abrasions heal very quickly.
One of the reasons I like seeing back the next day is it's miraculous. Most of the time, even if it's been pretty dramatic, it's beautiful the next day.
Yeah. It rarely takes 2 days. I mean, maybe if you slept your whole cornea, it'll take 2 days. And then the question always comes up, well, can we use a patch on the eye? Maybe it makes them more comfortable. And you can use a patch on the eye. The problem with patching is that if they're a contact lens wearer, which most kids aren't, but there was a study looking at this, and when you started patching contact lens wearers, you had Pseudomonas. Pseudomonas sort of grows more in contact lens wearers because it creates a sort of nice moist environment. So if you're going to patch a person who wears contact lenses or a history of contact lenses, they have more colonization with Pseudomonas. And then all of a sudden you get Pseudomonas corneal ulcers because you're creating more of a moist environment with the eye patch. So when I was in training, we'd say, we patch corneal abrasions, but we've never patched a corneal abrasion in a history contact lens. And so that was the dogma for years. But then all of a sudden, a bunch of pediatric ophthalmologists like, well, why are we patching all these kids? Why don't we just do a study to see if it makes any difference at all? And sure enough, it doesn't really make a difference, right? So these things heal up in kids just as quickly without a patch as a patch. If you want to put a patch on, you think it's going to make the kid more comfortable, that's fine, but it's not really going to make the corneal abrasion heal more quickly. And don't do it if it's a teenager who wears contact lenses.
In my experience, it doesn't seem to make a whole lot of difference for the comfort either, because eye's still moving around under the lid. And so.
Yeah, I would agree with that. I think the best thing is to throw your tetracaine in the office. They'll open up their eye, they'll feel better. They'll get out of the office, give me the ointment. They'll get home. Of course, the tetracaine will wear off and then they'll be miserable, but at least they're not in your office and being miserable.
If I see a foreign body, what should I do?
So it depends upon really on your comfort level. And I know pediatricians and a lot of pediatric ER docs who feel very comfortable, especially if they're sort of in rural areas. You just put some tetracaine drop in the eye and you take a Q-tip and you just sort of swipe out the corneal, that foreign body. And 9 times out of 10, they're these tiny little either metallic pieces or dust pieces, and they just come right out. Most of the time, they're not embedded that deeply. And that's what I do in the office. That's the first thing I do. I sort of have the parents hold the kid down, and a lot of times they're screaming, but I give them a choice. Either we do it this way, or I got to take them to the operating room and take them out that way.
Mm-hmm.
And 9 times out of 10, you just swipe a little bit on the cornea right in that spot, and it just comes right off. Now, you might cause a little bit of a corneal abrasion when you're doing that. The epithelium gets debrided when you're using your Q-tip, but that's okay. That'll heal up fine too. Occasionally, you can't get it out, or occasionally there's what we call a little bit of a rust material, and then that needs to be referred to your pediatric ophthalmologist.
Mm-hmm.
And the last one I had was about a week ago, and shoot, I tried to get that thing out in the office with a Q-tip. I even took a little bit of a 25 gauge needle, but I just couldn't do it with this kid screaming.
Sure.
So I had to put the kid to sleep in the operating room, and it took me literally 2 seconds to just flip the thing out of there. And then
Mm-hmm.
it wasn't that deep, but I just couldn't get at it. And then the kid did fine.
All right. We've covered a lot of ground.
Well, good.
Yeah, I feel a lot smarter. Let me summarize a couple of things. It's a good idea to take a history. It's a good idea to do a physical exam. I should pay attention to the ocular exam when I'm doing a physical exam, but I should also look at things that may be associated with the conjunctivitis as well. So doing a general physical exam is a good idea. I should use antibiotics intelligently. And when there are signs that this is something beyond a simple conjunctivitis, I should probably talk to someone like you.
Yeah, I would agree. There are less and less people going into pediatric ophthalmology, but, that's the way it is. So it means that pediatricians need to get smarter.
Well, that's why you're here, Mitch.
Oh, there you go. I hope I
get smarter.
I educated everyone.
Yeah, exactly. We're more competent than we were a couple of weeks ago. Well, thanks so much for your time over the past couple of weeks. I'm sure there'll be questions, and please send your questions to questions@vcurb.com, and we'll address those next week. But thanks so much for your time, for your expertise, for your ability to teach us. That was very helpful.
Yeah, my pleasure. Pediatricians are my friend. That's what I say.
And the thing is, we depend so much on good subspecialists like you to collaborate with. It's a two-way street, and we're so thankful for people like you to collaborate with. Well, thanks for listening. We'll come back for a Q&A next week. Thanks to Elisa Stoddard for everything she does to put this podcast together. And thanks, Janice, for listening. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who composed the theme music. See you next time.